Well, good afternoon and welcome. Thanks everyone for joining us this afternoon, and happy summer to you. My name is Catherine Wallace. I'm the program manager here at the Registered Nurses Association of Ontario and the program manager for the Best Practice Champions Network. I'm joined today by my colleague Andrea Stubbs, the project coordinator for the Best Practice Champions Network. And this is part of our monthly webinar series where we focus on all things to do with our best practice guidelines and in particular guideline implementation. This is a way of supporting our champions and other care providers who are interested in knowing more about best practices and about guidelines and how guidelines can be successfully implemented. From the evidence and implementation science, we know that there is no one way of doing this successfully, and so we use our webinar series as a way of highlighting the work that individual sites are doing. So we're delighted to have you with us today and are wanting to make the next hour as interactive as possible. We have 3 different presentations today, and that I anticipate will take about 45 minutes or so, and then we'll have about 10-15 minutes at the end to raise any questions for our presenters and have a bit of a discussion. Following the presentation then, this will also be archived on our RNAO website so that others are able to listen to the presentation. So today we are very fortunate to have 4 different speakers from 3 different organizations, and our focus is on multi-sites for our spotlight organizations, which are organizations who are actively implementing RNAO best practice guidelines. So they're going to be talking about some of the challenges, some of the lessons learned, some of their success in implementing guidelines across multiple sites. And we have representatives from the home health sector as well as acute care. So let me introduce our 4 speakers, and then I'm going to turn it over to Kristen Campbell at St. Eliz. So let me introduce the 4 speakers, and then as I say, we'll carry on with our presentation. So Kristen Campbell is a registered nurse with over 15 years experience. She is an advanced practice nurse for clinical infrastructure at St. Eliz Healthcare. She holds a Bachelor of Science of Nursing and a Master of Nursing from U of T. She champions continuous quality improvement and a person-centered approach to achieve optimal client outcomes and improve client experience. So we're delighted to have Kristen with us from St. Eliz, and she's going to be speaking first. Secondly, we're going to have Christina Zettler. Christina is the Manager of Professional Practice Portfolio at the Trillium Health Partners since 2012, and she is the Best Practice Spotlight Lead at Trillium, and she also leads other professional practice initiatives, including the Late Career Nursing Initiative, Nursing and Interprofessional Week activities, and the Clinical External Program. She previously held the position of Patient Care Manager in Medicine and Cardiology, and prior to this, the Manager of Inpatient Rehab Unit. Christina has a Master of Science degree from U of T, and she's currently doing some research examining the barriers to exclusive breastfeeding at Trillium. And then our last 2 presenters come from Sunnybrook Health Sciences Center, and they are both the Best Practice Spotlight Organization co-leads. So first is Beth O'Leary. She is a Project Manager Professional, Program Manager, a Senior Friendly Strategy at Sunnybrook, and she's joined today by her colleague, Tracy Dasgupta, who is the Director, Interprofessional Practice, Professional Practice. So we are delighted to have all 4 of these experts with us today, sharing their experiences working with our guidelines, with RNAO guidelines, and again, coming at this from the approach of working with multiple sites and how to implement guidelines successfully. So I am first going to turn it over to Kristen at St. Eliz and welcome her today and joining us for the webinar. And Kristen, if you'd like to take things over.
Okay, great. Thank you. Thanks, everyone. It's great to be here to share our experience with you today. So the title of this presentation today, it's just in our DNA. Vpso is who and what we are. So first, we just wanted to start by sharing with you a little bit about who we are at St. Elizabeth and the work that we do. St. Elizabeth has been an active participant in the development of personalized and home-based healthcare since about 1908 and is a national leader in responding to client, family, and system needs. We are an award-winning national not-for-profit and charitable organization, and we are known for a track record of social innovation and breakthrough clinical practices. We do have a team of more than 8,000 staff delivering more than 6.6 million hours of healthcare services annually. More than 95% of all healthcare services provided by St. Eliz are delivered in patients' homes. Included in our product offerings are staffing solution services, which provide short and long-term staff relief to healthcare facilities such as hospitals. We also provide service in long-term care facilities, schools, clinic settings, and group homes. So our vision for 2020 is to honor the human face of healthcare. And just briefly to share with you our mission, to share our talent and wisdom to serve the physical, emotional, and spiritual needs of individuals and families in their homes and communities. Inspired by our historic roots and traditional respect for human dignity, we strive to care with professional excellence and compassion. So St. Eliz is a national healthcare organization. So we do implement best practices nationally. St. Eliz has been a Vpso for the last 11 years. And our approach to BPG implementation over these past 11 years has been consistent and steadfast. This requires a team of people, so with the support and direction of our advanced practice consultants and our BPG steering committee, annually we have thoughtfully reviewed the list of BPGs to determine the ones that are most relevant to the work that we do. And key to this work is its connection to both our quality improvement framework for measurement, evaluation, audit, and feedback to staff, as well as to our professional practice infrastructure, so that being our policies and procedures, orientation, ongoing education, and documentation tools, etc. Okay, there we go. So where does our work take us? As I mentioned, we are in a variety of settings, and we implement across all settings. BPG implementation at St. Eliz includes a framework of selecting and confirming the BPG based on clinical relevance, need, program development focus, defining leadership and an implementation team. We review the BPG, identifying the elements and recommendations most relevant to the home and community sector, define implementation plan, including education, the audience, timing, updates, documentation, policies and procedures, orientation, evaluation, and measurement. This also includes plans to roll out, evaluate, monitor for sustainability, revisit the implementation plan, and add as we evaluate and as we see it's required. And again, that does loop once again back to our quality improvement framework for measurement, evaluation, audit, and feedback to staff. So just wanted to share with you, so our focus over the last couple of years have been on a couple of core guidelines, strategies to support self-management and chronic conditions, and this was led by our advanced practice consultant for chronic disease self-management, Glenn Chenard, as well as screening for delirium, dementia, and depression in the older adult, led by our advanced practice consultant for seniors care and seniors mental health, Robin Hurst. So some key accomplishments we wanted to share with you today include how we evolved and implemented these BPGs. So at St. Eliz, we are fortunate to have 2 certified trainers in the Choices and Changes Chronic Disease Self-Management Program. The Choices and Changes approach to chronic diseases self-management education training sessions were provided to our clinical practice coaches and St. Elizabeth preceptors and for all overall disciplines. And that was roughly approximately 275 St. Elizabeth interdisciplinary staff and leaders. So if you're not familiar, this program of education is focused on 4 key areas, which include effective communication and goal planning, the healthcare provider role, the client and action planning, monitoring and follow-up, which is fully in line with the RNAO BPG. We also provided additional education to frontline staff regarding a documentation tool that we developed titled Caring for Myself Client Self-Assessment. Although a documentation tool, it's actually a process that we developed for evaluation of the outcomes of client engagement and self-care with a focus on knowledge and self-efficacy. So this tool uses documentation to capture client self-ratings on 25 elements of self-care and management, which is completed on admission and again prior to discharge. Admission results are to be used by clinicians to develop a customized education plan for the client, and completion prior to discharge is to verify knowledge and competency gained. So at St. Eliz, we also have a large personal support worker population that delivers care at St. Elizabeth. So for our home support workers, we developed an OCAR framework as a means of enhancing the contribution of PSWs to the interdisciplinary team's work with extra training or guidance for the PSW as necessary. That outlines key functions of the PSW while providing care and working in a multidisciplinary team, including coaching, as directed by the regulated healthcare provider. So this framework is critical to enabling our unregulated care providers to fully engage and participate in supporting implementing strategies for self-management. So the wisdom strategy was the wound self-directed management model is a transition from the traditional episodic method of care delivery to one that engages clients and healthcare providers in learning self-management strategies to promote independence in dealing with the underlying causes of non-healing or maintenance wounds such as chronic disease. And it was designed to take clients with a longer length of stay and teach them self-management. So just to discuss progress to date briefly. So of course, this involves continuously evaluating what we do and the BBGs that we've implemented. So what we learned is that timely access to wound specialty nurses is essential. Gaps in this area were identified specifically in one of our service delivery centers. Regular caseload reviews are essential to ensuring appropriate treatment, care, and coding of the care that's required. And client coding, and that's something we do internally here at St. Elizabeth, needs to be improved to help identify wound clients from those requiring treatments only, such as high compression bandaging. So really the importance of a thorough holistic health history to understand essential elements in healing and health concerns. And knowledge translation needs to take place in a number of ways, including education, documentation, client education, feedback through QI reports, and membership, which is essential while learning a new way of thinking and practicing, mentorship. And we also recognize that within the home care sector, there are constraints that are really beyond our control. There are cultural, environmental factors, things such as client access to supplies to allow discharge. We do have clients that we all see that refusal by the client or caregiver to participate in the wound care strategy, or no access to support at home for some clients who aren't able to manage independently. The Caring for Myself client self-assessment is being moved into routine monitoring through regular chart audits, and plans are in place to complete a more robust evaluation of pre-post changes for our clients twice annually. And these results we use to drive improvement activities and will be directly shared with frontline staff. So some key accomplishments that we also wanted to share with you today. Related specifically first to the screening for the 3Ds, we wanted to build capacity within the organization to support documentation and implementation of best practices for caring for the older adult. So we needed to support, that support in our clinical education area, our clinical practice coaches and our clinical practice resource team. So 2 fellowships were used for this purpose. The fellow created and implemented education across nursing and personal support, and rehab integrated geriatric assessments into their practice. We wanted capacity and champions within the group practices, so created the Knowledge to Practice Seniors role to help with discussions about frail clients and documentation. The Knowledge to Practice role, just to explain that briefly, is a role that we developed to support all nurses to increase knowledge and skills within their nursing teams. So this is an individual. We provide access to the resource nurse and clinical specialty areas who can problem solve client care issues when needed. We also used a Canadian Patient Safety Institute Falls Collaborative to make use of the K2P role in supporting falls prevention.
Trying to give me a compliment. It's in subject and you'll call his wife. We're checking,
So again, looking at progress to date, documentation was fully implemented, integrating and integrated into usual documentation tools. We had to also set up supervisory visits to make sure the personal support workers were implementing the education in practical terms. So for example, improving client safety, involving clients in exercises and reducing hazards like rugs, cluttered areas, for example. We then set a target of reduced falls, and I don't have that specific number at my fingertips, but we were well within the target that was set. Okay, so this just is a slide that represents the BBGs at St. Eliz that were implemented or in progress. And as you can see, there are a number of BBGs over the years that we have implemented at St. Eliz. We do support our nurses with joint visits, as well as we do have 24/7 phone support for problem solving and decision making, where there may be questions related to the care that's provided. Okay, so just to move towards the end here, lessons learned. So our Vpso activities with respect to guideline implementation over the past years have included the involvement of key nursing clinical practice infrastructure teams. You've heard me mention these names before, but the clinical practice resource team, our clinical practice coaches, discipline-specific practice leaders, including the advanced practice consultants, professional practice leaders in therapies, and our personal support supervisors for our unregulated staff. You also heard me mention our knowledge to practice networks for seniors, led by Robin Hurst, and our preceptors. What we learned is that there's a high level of consciousness and awareness required from staff with respect to BBG implementation in order to achieve practice transformation and desired outcomes. What we learned is really depth is essential to true sustainability. So we did learn that if the best practices are implemented in a superficial way, that does not always result in the depth of impact or outcomes that we truly desire. So just lastly, where are we at after these 11 years? Although our outcomes have been excellent, with wound healing, pressure ulcer prevention, falls prevention, screening of the older adult, In the spirit of continuous improvement in our quality guarantee, we're looking for even greater outcomes through increased awareness, consciousness, and depth. So we are proposing moving forward with a Vpso refresh for the period of 2016 to 18. So what does that mean? So we're looking at, for the next period, being spent reviewing key VBGs already implemented, looking at 5 specifically with an eye on depth and quality, and ensuring that initial recommendations implemented have been fully sustained, and determining if other recommendations could now be integrated into this work. And that really wraps up, I think, where we're at.
Great, excellent. Thank you, Kristen. And after we've heard from the 2 other presentations, we should have some time for some questions. Certainly the task of implementing guidelines nationally is quite daunting, so I'm sure that we can have some more discussion. So thank you for that. And now we'll turn things over to Christina Zettler from Trillium. Thanks, Christina.
Hi, thank you, and thanks to the RNAO for inviting me to tell our story today. Just a few quick facts about Trillium Health Partners. We are fairly recently merged. I think it was 2011 when we merged with the Mississauga Hospital, and the Mississauga Hospital included another site, the Queensway Hospital, as well at that time. So we have really grown and are continuing to grow. We have construction going on at present, and have a plan in the next 5 years to increase our beds once again. So over 3,200 nurses work here, lots of allied and physicians and volunteers, and anyway, very busy spot, lots of emergency visits as well. So, as I said, we merged in 2011, and the impetus for becoming a Vpso was really to standardize practice across those sites. So this was really a key strategy for making sure that the practices were evidence-based, and that if you walked in the door at any of our sites, you would receive the same quality of care as you know, anywhere you entered the system. So we also wanted to fast-track this initiative because, as you know, it can take years to really work through some of these issues and get everybody on board with a particular practice. And it was really a unifying process in becoming a Vpso. So we achieved our designation, and I apologize for that little spelling mistake, but we had a big celebration in 2015, as I'm sure some of you on the line have had. I know Sunnybrook was in the same cohort as we were. And these are some of the guidelines that we implemented straight away. So we chose our guidelines based on areas where we weren't doing so well as an organization, perhaps, such as our picker scores were low in the area of pain management. That was one of the ones that we chose. And others were chosen because we had programs in place at one site or another, but we wanted to, as I say, make sure that those services and quality of care was available across all sites. And we threw in a 7th one. We had some P&I results for decubitus ulcers that weren't too favorable. So that was another one that we implemented after we'd sort of started on our journey, which has really benefited patients across our organization. So in our post-designation period then, we're looking at caring strategies for people with delirium, depression, and dementia, assessment and prevention of workplace violence, and end-of-life care in the last days and hours. So these are really 3 massive guidelines that, again, going across all our sites, except the Queensway site is mainly day surgery, but less so for some of the guideline, but certainly the assessment and prevention of workplace violence is being implemented there, as we have an urgent care center that's open, I think, 16 hours a day or so. So that's about, that's our background information. Sorry. So what we found that was really essential to making sure that you have success in implementing across sites is to really start with strong leadership. And the key to that was choosing the right co-leads. So we have a co-lead at each site for our implementation, and that person has to be someone who has strong and positive influence in the practice area. So I think most organizations know who those people are. If you look around and you know those people who are movers and shakers. They get things done. They question practice. They have high standards. And those are the people that you want to be leading your best practice guideline initiative. But the other thing those people need is to have dedicated time to commit to the initiative. So it's not enough just to have that person who has positive influence, but they need to have the time to work on the initiatives, particularly at the beginning when you're just getting started. So we have had educators, managers from any discipline, CNSs, nurse practitioners, because those people have a percentage of their FTE dedicated to professional activities. We also, though, for those people, built in some accountability. So we have a steering committee every month, and the co-leads we requested of them a written update that was circulated ahead of the meeting, and that way we didn't spend the entire meeting updating on each guideline, but we spent the time in the meeting looking at where were the barriers and troubleshooting some of the issues that they were having. I met as the lead with the co-leads every 2 weeks, and that sounds like a lot, I know, but as I say, in the beginning it was necessary, and it really helped for team building across sites as well. So these are practitioners who didn't know each other before we started with the Vpso journey. They also, because our merger was fairly recent, they hadn't encountered each other in meetings or what have you, and so a lot of them were, perfect strangers, suddenly thrown together to lead something at cross sites. So I found those 2-week meetings really helped to bring us all together and make sure we're on the same page. And this is an example of the status report that we used, and there's lots of them out there. I got this from our project office, and it's a part of it, of course, but it really grew and grew, and you can see that it identifies the milestones, and it identified what was needed to move us forward to the next level. And so, as I say, I would ask that this would be completed, but it wasn't hard. It wasn't hard to complete. We're having some background noise here. I don't know where it's coming from. Anyway.
I'm just going to mute all of the lines. So, Christina, once I've muted them all, if you just want to press *6 to unmute yourself.
Okay.
The conference has been muted.
Okay. All right. So I think as a lead, I really needed to strike the balance between, killing the leads with paperwork versus, having a tool that's easy to complete and keeping people on track. Some of that role for the co-leads involved reaching consensus because the practices were very different at some of the sites, and doesn't mean they weren't evidence-based, but and we didn't have to have all processes alike, but we did want to make sure that the practices themselves were consistent. So things like using an evidence-based assessment tool, that was essential. Who did that assessment and where it got filed in the chart, not essential. So if you look at what is really important in making sure that practice is consistent, it really is more about the practice than the process. The co-leads really need to have knowledge in the area of change management and take leadership when challenges arise, know when to bring things forward. I myself would help with trying to troubleshoot some of the issues that would come up. And some of our challenges involved, we have two different databases. So we have SCM for documentation at the M site. We have Meditech at CVH site. And so any report writing that was required or any changes through informatics with embedding the content of the guidelines into the documentation was really double the work. So we had to have informatics folks who knew both of the systems and could go back and forth between those systems, and some decision support people as well who could finesse both of those systems. And of course, anytime it's best to pilot. I didn't have a slide on this, but I should have. It's really best to pilot some of your initiatives because sometimes we would make a change and then realize it didn't work perfectly, and then the ripple effect for those supporting departments is big. So they have to go back in the system, change things again. So that was a lesson learned for us. Okay, so one of the strategies as well that really supported the Vpso initiative was to implement the leadership guideline. So we started with that one back in 2011 and put together a program that has once a week attendance at an 8-week program for charge nurses and professional practice leaders, and that program has been enormously successful. It helped at that time to get increased leadership in strategic spots throughout the organization. Again, if you're a charge nurse, you can influence the practice in your unit when we're trying to implement a number of guidelines in medicine, for example. We had some external funding to do this through our foundation and through the TD Bank, and our attendees are from across all sites. And again, it allowed staff to get to know each other because they were together for once a week for 8 weeks, and they were given a project to work on during and at the end of their course that they had to present at their graduation. So these are just some of our graduates. The attendance is interprofessional, so we have people from all departments participating, and one of the key pieces to our leadership BPG was that for a year following the course, those leaders are matched with a mentor within the organization, and that mentor helps them to troubleshoot any of the change initiatives that they're working on, and with their practice improvements, with their communication. So the mentors meet at least every month or two with the leads or with the leadership graduates to work on their changes. So that was really a great strategy. One of the other things we did is we made efforts to align equipment across our sites. So we put in a fall prevention initiative, and part of that included doing a trial of a low bed. We trialed the bed across sites, and then we purchased that bed through capital, and that was through Vpso, through professional practice. We made sure that there's a good group of beds available for fall prevention. We looked also at therapeutic surfaces. How many do we have? How many do we need? Aligning dressing supplies across sites so that we're using the same products, and other equipment like pressure reducing cushions that had worn out. And we continue to use that strategy to try and make sure that we have the right equipment available to staff. Some environmental considerations. As you know, culture can be a real challenge, culture differences, but we decided to not look at it as a barrier, but as to embrace it and work within it. So the co-leads, of course, are intimately familiar with the culture in their areas, and when we would present ideas, you know, will this work, will it not, what needs to happen to make sure that the culture doesn't eat the strategy for breakfast, as they say. And so we really were conscious of those things, and we worked on those things. Of course, with any initiative, you may have naysayers among your group, or people who are not on board with the changes. And my advice would be to you know, to use your Vpso clout. It is a corporate initiative, and we had to you know, play that card a couple of times and say this isn't an option for your area. You need to put this practice in place. We will help you to do it, and we need to know why it's not happening and what your barriers are. But at the end of the day, you really need to help to promote the practice. So some of the other issues were around budgeting for education. The managers have, of course, control over their own budgets, and education can be expensive to send you know, a multitude of staff to various workshops and so on. So again, we had to work with managers to say, you know, if you're running over budget, we still need to do this. It's an explainable variance, but it is part of our corporate initiative and needs to happen. And we used analogies like accreditation, for example. You wouldn't just not do it because you're struggling with your budget. Of course, you need to do it, and again, support from senior leadership on getting that done is key. This is an example of one of the tools that was developed on one of the units, and this is for purposeful rounding. And this tool really took off. Some of the units had different things they were trying, and this is an example of when one unit has a good idea and they put something in place, you know, spread the word, get it out there. And speaking of spreading the word, we engaged our communication and public relations team to help us to make sure that everybody knew what Vpso was, everybody knew what VPGs were. They would say to us, what is the message that you want to send this time? What is it that you want people to know? And then they would help us with, you know, championing the various communication activities. So making sure it's in newsletters, getting our web page going. We have interprofessional rounds where we're presenting on different guidelines. When it's Patient Safety Week, we will have a poster about fall prevention. And of course, we took advantage of the RNAO funding for champion breakfasts and so on, and had guest speakers in to, again, raise the profile of the work, celebrate the achievements and so on. And this is last slide. Just there is no end point to this work. So if you think you've arrived or you're done, that isn't really the way it works. And but there are certain indications, I think, that helped us to know that we're making a difference. And one of them was Enquire, and looking at our Enquire data and seeing our fall rate, for example, take a nice decline. Looking at our skincare results as well helped us to know that we were making a difference. Then we'd have the stakeholders come forward and say, oh, there's this guideline I want to implement, and we'd have to say, well, if it's not one of the ones that we're presently doing, we can't take it on, but you know, here's some advice on how you can get things going and so on. And we also had a couple secret shopper experiences where people were admitted as patients who were, you know, working here and would say, you know what, I was screened at registration. They asked me about falls, or, you know, I was rounded on. I had good pain management and so on. So you know you've arrived when. And yeah, so without further ado, we'll move on, I guess, to the next speaker if there's no questions.
Just remember to unmute your line by pressing *6.
Thanks, Christina, for your presentation. I think we'll give the floor now to Beth and Tracy, just to ensure we have ample time for them to do their presentation, and then hopefully we'll have some time for some questions at the end. Thanks. So, Beth, I hope that Tracy has been able to join you there, and hopefully you can see your slides there on the screen. And Beth, you just need to unmute your line to *6.
Can you hear us?
Yes, we can now. Thanks, Beth.
All right, perfect. So it's Tracy speaking,
Hi,
and I'm going to start.
Wonderful. Thanks.
So we're going to be speaking, obviously, about best practice across multiple sites, and we're just going to
just that
here.
Yeah.
Do we flip or do you flip?
You flip.
Okay, we're just trying to flip.
Okay.
All right.
If you're having
we're not flipping very well here. We push the arrow. Okay, there we go. Sorry.
Okay, so we want to speak specifically to some of the strategies that we have used, seeing as we've got 3 different sites and 3 very unique sites. And within that, we want to talk a little bit about how we've engaged champions across not only the organization but within the sites, recognizing that we've been doing our best to promote standardization while at the same time recognizing the uniqueness of each of our settings. So just a little bit about Sunnybrook, and we won't spend a lot of time on it, but large academic health science center. You'll see how many beds we have. We obviously are a system partner and, you know, reach out across the continuum. And just a little fun fact at the bottom, we drink 13,000 cups of coffee a day. So our best practice journey has really taken us over 4 years, and at this point we have 500 champions, and they are interprofessional champions that cross all of our, I'm going to say our professional groups, but beyond our clinical teams as well. And as I did mention, 3 campuses and additionally 8 programs, which are also recognized as unique within the organization. So the slide you're seeing now is our structure slide, and we paid a lot of attention in the beginning to how we developed our structure because we knew that the structure was going to support how not only we were going to be able to build our teams, but how our teams were going to communicate and what roles individuals would play within the teams. And you'll see the green across the bottom is frontline staff, and we put the most significant effort on building capacity within our local leaders because it is our local leaders that are in fact driving the change. So I'm going to, we can flip there. So as we got started and began to think about what the work was that we were going to do and how we were going to implement guidelines, not only with success, but as we had said, within areas that in fact had great diversity, we knew we needed to have buy-in early. And I'm going to say the first 1 year, even up to 2 years, was spent dialoguing and really trying to have organizational inquiry to really understand what the voices in our system were saying, not only about change, but about the way people were currently working and about what people knew and understood about evidence-based practice. And as part of that conversation, it was really embedding the understanding of why this was important and what difference it would make for not only the staff who were implementing the change, but also for obviously the patients and families we were working with. And at the same time, we wanted to connect that work with work that was already ongoing. So it wouldn't be viewed as something new and different. It would be viewed as completely aligned. And we wanted the work to be aligned with the local priorities, but in addition, to have alignment with our strategic and corporate priorities as well. And just in the previous presentation, we did hear about the concerns or that not everybody is going to come on board along the way. And we really did try to create the space of trying to understand what the concerns were so that they could then be moved and transformed into solutions that would help us make our change so that, in fact, everybody would be part of the story of our future. So the slides you're looking at now really speaks to the output or the outcome of the multiple conversations that we had, starting with our executive vice presidents down to our directors of operations, through our advanced practice nursing leaders and our patient care managers, to really understand in terms of the work that we would be implementing, how would that fit and what would the timing of that implementation look like. And so you'll see each of our best practices down the left-hand side, and across the top you'll see the quarters. And that was us working together and collaboratively, really trying to determine when we were going to be focusing on change, what would that timing look like, so we knew that there would be capacity within our teams. And one thing is implementing the best practice. The other is knowing and understanding why. The third is understanding when it's going to happen. But the fourth was really putting a frame around what that process would look like. And we adopted the NHS sustainability model. So the slide you're looking at right now is really our modified version of what that sustainability model is, with a focus on building people, building processes, and really connecting our people and processes across the organization, with the organization, again, representing the diversity of people, of the patients we were caring for, and of the priorities that we're truly living. So here's a picture of our people. These are our champions, and if you flip to the next page, you'll see what we did within our people, working with our frontline champions, was really elevate some of our frontline champions into change leader roles, giving them, so all of our champions participated in a quality improvement development program called iLead Foundations, which gave them the basis of best practice implementation, and through that we developed some further core leaders that became really formalized mentors across each of the settings, and you'll see some of our individuals here. And we're really proud not only of these individuals, but also what they've been able to accomplish, and I think it speaks to the process and the opportunity, because as you look at each of those people on the screen, they have in fact gone on to other more formal leadership roles, including our professional leader for nursing, including master's program, shift supervisor, and a core focused work in quality improvement. So I think that really speaks to the success of the program. as you build the work that you're doing and the what and the why and the where and the timing, the big message that we heard coming out all along the way was role clarity. And our champions and our leaders, so both, all communicated very strongly that in order to participate in the optimal way or in the optimized way, they needed to have a very clear understanding of what their roles and responsibilities were. So on this slide, you'll see Courtney Miller, and Courtney Miller is a change coordinator who started off as one of our champions, and in her role, she reached out to champions across all of our settings and really worked with what they hoped to achieve, what they were struggling to achieve, and what tools they would need to help them be successful. And it resulted in the development of a role profile for the iLead champion, and what you'll see just under her photograph is an iLead champion toolkit. And it's really the building blocks of you've decided to be an iLead champion, and now what? And within it, it speaks to tips, very practical tips and strategies that iLead champions can use in their formal setting, in their clinical setting. And Courtney, in her role, reaches out to new champions in a trifecta model in which she meets with not only the champions, but the advanced practice nurses and the patient care managers of that area, enabling and supporting them to be successful. And I'm going to pass it to Beth. Do you want to talk to them?
Hi, it's Beth. So Courtney as well has created this, it's in a Survey Monkey, and basically she sends this out to champions, and this has gone out, our intent is for this to go out twice a year. It's gone out 3 times now, and it goes out to all champions, and it asks them a whole range of questions. The slide that you see is their are indicating which site that they work in. The questions are with respect to which best practice they're aligned to, what strategies that they use when they engage their colleagues, you know, what works well, if they feel supported. There's an ask for them to tell some stories. And so this has been really something that sort of is really growing in meaning for us. Because it's really giving us the lay of the land over time in terms of how best champions are feeling about the work, and some of the things that they have, that they, you know, are saying that they need in terms of support. And so we're really trying to pay attention to that to make sure that the things that we do respond to what they're telling us. So this has been great. We just have our 3rd activity report out now. The results are coming back, and Courtney sends the results to all of the sites, the programs, and the best practice working group leads. So when Tracy talked a minute ago about people, process, and the organization, so just a few slides about process. So when we think about process, what we think about is we think about enabling, providing champions with data, so that they know and understand what's happening with respect to their best practice, and we provide them space and encourage them to have space to then engage their colleagues to have conversations about what's happening with respect to each of their best practices over time. So this slide you'll see is sort of an iterative process about what we're trying to do. So we're releasing a dashboard, and each quarter we're providing champions with education and support to understand what's on the dashboard. Middle leaders are asked to create space and to support champions to have conversations with their colleagues about what they see in the data, and then what the success is that those various teams achieve. The anticipation is that those are then shared in structures that we have, and then those individuals are profiled organizationally aligned to enhance patient outcomes. And so that's sort of the structure that we have established. And you'll see on this slide, this is actually just a screenshot of the front page of our dashboard. Essentially what it does is it provides information in quarters for champions to understand each of those best practices and the outcome indicators for each, with some color coding to sort of say where we're at relative to our target. So when we think about what this looks like when it's done well, so champions have received the data, They understand and they grow in understanding of the data over time. And so then they engage their colleagues about patient care priorities. They talk to their colleagues about what the data is telling them. How are they moving collectively towards the target? So understanding, you know, last quarter, last year, and current state. Understanding as well other areas and how they have done with respect to their best practices and some of the initiatives they've used in areas where they have better results and better improved patient outcomes. And then engaging colleagues in, you know, what do we need to do to continue to improve? And, you know, continuing to have that conversation in each quarter. So in terms of the third sort of pillar of the NHS sustainability model, so the organization, I'm just going to kind of go quickly because I see we have sort of 4 minutes. So we have a couple of ways that we bring champions and the organization together. We bring champions together every quarter in what we call iLead Champions Connect, and twice a year we reach out to the organization to a network event. This was what the picture on the right is actually our most recent network that was held in May, and the duos in each of those pictures, the pairs, are actually a champion and manager who came together, who used the hour to talk about how they work together to make best practice live in their particular patient care area. This was a network event that we ran last year where it was grounded in, if I use the optimum of best practice, you know, I would be somebody that you would want on my dream team. So this was sort of grounded in people passing cards to one another and recognizing their peers for the outstanding practice that they exhibit. This is actually an initiative that was begun within our nursing council structure, and actually as of tomorrow is starting to spread broadly across the organization, and we have this for the first year on our quality improvement plan, and it's where we are asking staff, champions, and leaders across the organization to talk with patients about their experience. So every quarter at the same time, the fourth Thursday, 10:30 to 11:30, we go out and specifically ask patients about their experience here at Sunnybrook. And we're thinking that over time that's going to give us some really valuable information to know what, to have the patient's voice at the table. This is some of our data, and I'm going quickly here. We have used our intranet resource to ensure that we, you know, house our tools there. These are some of our patient partners, and we all know that this is why it matters. So when patient partners come to the table, the conversation is much different, and it's much more about why we do what we do. I don't know, this is a story that Tracy tells about murmuration, and there's actually a video that goes with this, and it's quite an interesting concept that
and really the point there is just all these starlings all fly together, and so what is it that makes them all fly together, and what can we learn from the starlings? So that's really the story, but we wanted to end with that because, you know, across sites, across campuses, across diverse people and priorities, that we need to find a way to work together, and it really does come through true collaboration and speaking to both, like I said, standardization, but also finding meaningful ways to partner. And I think that's probably been our biggest learning along the way, and again, really grateful for the opportunity to be on this journey. And that's all our stuff.
Thank you, Tracy and Beth, for that presentation. Very inspiring, the work that you're doing at Sunnybrook. I really want to applaud you for all of the work that you're doing. I see that we have unfortunately run out of time, and so I want to thank all of our speakers, and for those of you who attended. I think we've heard some great examples of great implementation work and some great takeaways. I think certainly Kristen emphasized the importance of the depth of implementation if you're wanting to have sustainability. and the importance of not being superficial with implementation. Christina really emphasized how BPGs can standardize practice, and she emphasized leadership, as did Beth and Tracy, and the importance of that for frontline staff in order to build that leadership and accountability. She also emphasized communications and getting the word out there in terms of guideline implementation. I also liked her takeaway about using Vpso clout and corporate clout when necessary, hopefully not something needed to be used on a regular basis, but certainly for those strong naysayers, and also the importance of piloting initiatives before scaling up to other sites. She also emphasized the importance of culture as a component of implementation. And I think from Tracy and Beth, from their presentation, the importance of role clarity for champions as a way then of building in the understanding of the expectations, to build in accountability, but then also the celebration of the accomplishments, bringing it back certainly to the patients to ensure that they feel that they are really receiving the best in care, which is ultimately the goal of best practice guideline implementation, and the emphasis on staff in building their leadership and in building their buy-in. And I liked your point in terms of engaging them and understanding their concerns. They're really trying to take time with that step as you move towards implementation strategies in order to get that buy-in, to really start from the strongest place. So I thank all of my speakers today. I'm so pleased that we were able to have this webinar together. We've been working on this for a few months, so great to get all of these leaders and just be able to pick their brains and learn a little bit more of what they're doing in their organizations to support successful implementation across multi-sites. I thank all of you for attending, and you will receive from us an email within the next 48 hours, a short evaluation survey just asking you for some feedback, and then from that, then you're able to print a certificate of completion. So we will continue to hold our webinar series and hope that you can join us. And again, I thank my speakers and thank all of you for attending today and hope that it's been helpful for you. So thanks very much, everyone.
Bye-bye.
Thank you.
Bye.